Hello everyone, my name is Karen Scott and I am a Senior Training Specialist at TruCode, and today we are going to be talking about addressing outpatient procedural coding challenges. So today we're really going to focus in on CPT. So just a little bit of housekeeping. You are in listen-only mode today. Because we have so much material, we are not going to be able to get to any questions today. However, we do have Sharon behind the scenes. If you do have any kind of technical issues, go ahead and send those questions. If you do have any questions about the material, you can go ahead and send them as well, and we will try to address those, and we will get you those answers after the presentation today. We just have a lot of information to get through when you start looking at coding with CPT. I've been starting to do a lot of classes right now on the update, so today's not really an update class, but just trying to keep up with everything that goes into the CPT code books every year. So because you are in listen-only mode, you can see over to the side, you have the little right-hand side of your screen, you have the control panel. If the control panel is in your way, just find where there is the little orange box with an arrow in it. Click on that orange box and it will move it over to the side of the screen. Also, your handouts at the bottom of the control panel under handouts, you will see it says handouts 1 there, and you can simply click and open up those handouts, and Sharon's going to talk more about that and how to get your CE at the end of our presentation today. So I've got a lot to talk to you about, so I'm going to go ahead and get started with our presentation. Again, thank you so much for joining us. So here's our agenda for today, and again, it's a lot to cover in 1 hour, but I'm going to try and give you some kind of a snapshot or kind of, I don't know even know what to call it. Basically, just examples of things that I've seen over the years in coding CPT, things that have been problematic, and I'm trying to go through everybody's system and give you a couple of tips in each area of the CPT surgery section. So we've got that. We're also going to get through some of the modifiers as we go through today, and as we go through also we'll talk about resources and using resources to help us find the correct code. So we'll talk about those also. So I'm going to just go ahead and get started, and starting with the integumentary system at the beginning of the code book. Again, just because of the time frame today, I'm not going to make you flip to pages or anything. I'm just going to tell you about things that I have seen as far as problems or areas that might be helpful tips for you in going through and finding these different codes. So as we start at the beginning of the surgery section, the first one is the skin or the integumentary system. The first one that I think is problematic is under the removal of lesions. Remember, whenever a lesion is removed, basically the first question you got to ask, and hopefully the documentation shows you, is it an excision or a destruction? Remember, excision is where you have a cutting off of that particular lesion. Anything other than that is going to be a destruction, and destruction can be laser, it can be cold, it can be heat, it can be using chemicals to destroy it. So sometimes the doctors will say we removed 4 lesions, but actually one of them was done with cryotherapy and one was done with an excision. You also want to be careful too. This is where I see a lot of edits pop up when we're trying to do multiple codes. Lots of times when the dermatologists do remove the lesions, they may do several things at the same time. You're going to need a modifier on those to be able to show they're separate. For example, if I have a lesion where the doctor wants to do a biopsy of one of them but actually wants to remove a second one, then that's going to hit an edit, and I'm going to have to use a modifier to show that those are separate from each other. It's not the same lesion, it's 2 separate lesions. So I find that I use a lot of modifiers in this area because lots of times they will take off more than one at a time. Remember, there are codes for shaving if they have to do shaving or like a shave biopsy, or paring, again depending on the type of lesion removed, if it's a wart, if it's a corn, whatever it might be. You want to make sure you are using the correct code there. You also want to be careful with a lot of these codes because they'll see things in this section like each or every or up to and including, and so you want to make sure that you're watching those very carefully. And and they're different. Every code is different. You just have to pay close attention. One will say each, you know, it'll have one for the first code, and then there'll be a second code. It'll say like from 2nd to 14th lesion each. And when it says each, that means you're going to use the first code for the first one, and then if it says each, if that patient has 12 lesions, well, you're going to use that second code, you know, the number of times as for the second lesions. So usually you'll do that with the units box. So if they have 12 lesions, I use the first code first, and then use the second code 11 times, and I put the 11 in the units box. Every once in a while you will hit an edit about a maximum number, and so typically we're okay on these codes, but watch out for those in your edits as well. The other big important thing with your removal of lesions is making sure that you are checking for specimen size. Remember, when a lesion is removed, they usually don't just remove the lesion, they also remove information, or excuse me, they remove normal skin around it, and they'll talk about the margins, and so they're going to remove not just the lesion but margins around it. So you want to make sure, and in your CPT book or you're a CPT assistant, there's some great articles that talk about how you measure that. So for example, if I have a lesion that's 2 centimeters and then they also remove 2 centimeters of a circle around that, I'm going to actually code that to the 2 centimeters of the lesion plus 2 centimeters on top of the lesion and 2 centimeters on bottom of the lesion to show the whole amount that has been removed. So that actually is going to be 6 centimeters. So I see a lot of issues with specimen size, and so you definitely want to make sure that your documentation is there. And again, in the code book and also in your CPT assistant articles, it explains that, and they have some really good pictures to assist you with coding that appropriately. So that's the first thing that I see there. Now, also within the integumentary system, I also get a lot of questions about biopsies, and you do want to make sure that you're coding those correctly. Again, remember, biopsies, if they are done, if they biopsy a lesion and then they remove it, that is considered to be incidental, or if a biopsy is taken while they're doing something else, another procedure, that's incidental as well and is not coded separately. The only time that you will do a separate code is if they, for example, biopsy one lesion and then remove a different one, and that's again where you're going to need a modifier, either a modifier 59 or one of those X modifiers, which we will cover in just a little while. Also, in 2009, they added when you had secondary codes, which had maybe the first one was from 1 to 5 lesions and the next one was 6 to 12. They added in terms that say or part thereof, and that means that you would be able to use that second code even if it's a little bit over. And that can be also in the codes where it is a measured amount, like when they are removing big entire information, they're moving a like skin grafting, those kind of things. It'll say first 50 square centimeters or first 20 square centimeters, and then you have an add-on code for each additional 20 square centimeters or part thereof. So that helps us know when can we start using the second add-on code and how much do they have to do to be able to use that code. That's happening in areas like skin tags and so forth. So again, use the second code for any amount over the first stated amount. And again, this should be pretty clear in the code book, but I just think that that's sometimes problematic. With excision of lesions, when they're actually excising the lesions, when they're cutting it off, remember there are different codes for benign lesions versus malignant lesions, and you want to make sure that you're coding those appropriately. You also can review the path report to make sure you're coding the correct procedure, and also that can help with the sizing if the doctor does not give you the sizing. However, you do want to be careful because of the fact that sometimes if they remove a lesion and margins and then they put it in the preservative, send it to the pathology, or pathology puts it in a preservative because they can't get to it for a few days, sometimes being in that preservative shrinks it, so you actually may get a lesser sizing, which means a lesser code, which can be inaccurate reimbursement for your physician or for your facility because of the fact that it's not accurate according to what was actually removed. It is better if you can have have discussions with your physicians to make sure that they know that they need to give us that information on the operative report so that we can have that and be able to code it appropriately. And there is no question. I just don't want to see them missing out because they are not giving us the documentation, and we're left to find it wherever we can. And again, that's where the issue becomes a big deal there. Now, when you are removing a lesion, normally remember everything that is included as part of a procedure is not coded separately. So, for example, if you have a lesion on your arm, they're not just going to leave a big old gaping hole on your arm. They're going to sew it up. So just a simple repair, which is a separate code, but a simple repair is included in the excision codes. So if they use just a single couple of stitches or something to close that hole up, then you would not code it separately because that just makes sense. It's common practice. However, if they do an intermediate or complex repair, that is more than just the normal sewing up the hole because we're not going to leave it open. So you are able to code those additionally. You just want to be aware of the fact that there are very specific definitions when it goes from simple to intermediate, when it goes from intermediate to complex repair. Again, those are all in the code book. Just make sure you're watching them carefully. And please remember that a layered closure is not necessarily the same thing as intermediate. They have to go at least to the fascia to be able to consider it to be an intermediate. Or you also can, if a patient has a lesion where there is, there's a lot of information there, you may be able to go with a higher level there, like for lacerations, for example, if the laceration is gravelly or you have to do a lot of work there. So you can use those in different areas there. The other thing I want to remind you about with lesions is that there may be times when the first lesion they remove the lesion and then they find that they didn't get all the margins clear. They may come in a second time to remove more of the tissue, and so then in the second excision, when the pathology report comes back, it says it's clear, that there's nothing there. And so people are sometimes trying to figure out, well, how do I code that? Is that an excision lesion of a malignancy or is it benign? But remember, they're still treating the malignant lesion, so you are still going to code it as whatever they remove that day as excision of the malignancy there, and that also helps with your diagnoses as well. Now, if you do have multiple lesions, remember those are not added together. If there are 3 lesions that they remove, those are 3 separate codes. You don't add anything together like you would on lacerations. Remember, when you're looking at sizes on those lesions, if it says the lesion was 2 by 3, remember, then you would then not multiply that together on our lesions. You would actually just pick the biggest size. So in the example here, if it's 2.5 by 1.2, you're going to use the 2.5. So that's different than it is on our skin grafting. So just be careful to use those terms correctly and the right information there. A little bit more on our wound repairs. We talked about it just a moment ago when you have a lesion removal, but when you got someone coming in with a laceration that they have to repair, same codes here, simple, intermediate, and complex. You do have to know the size of the laceration. These don't go to pathology, so if your surgeon or your ER physician does not give you the size of the laceration, then you are left in a bind. And if it's if they spend a lot of time sewing it up but they don't give you that size, then you're either going to have to either query the doctor or you're going to have to use the smallest level, and that's not, using the smallest size is not really a good option. But you've got to know that there is not an other or I don't know what size laceration. You have to have that. I remember one time my daughter cut her arm, and I took her to the emergency room, and the first thing the surgeon did, the ER doctor, he took out his ruler and he measured it and he put that in the chart immediately before he did anything else. And I was so proud of him because I thought, oh, that's going to make your coder's job so much easier there. Remember, there are notes in the code book that tell us if you do have more than one laceration or wound in the same category, then you would be able to code them as one repair. Example here, this patient has 3 lacerations on the face. They were all done with simple repair. One on the forehead was 1.5 centimeters, the cheek was 2.5, and the other cheek was 1.2. That's when you would add these 3 together and code it for simple repair of the face, and the range of that code is 5 5.1 to 7.5 centimeters. So that's different than when you have multiple lesions. You want to watch those laceration rules. Remember, these rules are in the code book, so you just need to make sure you're watching those very carefully. Please remember also that debridement or debridement and cleaning wounds are not coded separately unless they're either carried out at a different time than the repair or are very consuming or difficult. So those are things you want to look at. Remember, again, as I mentioned earlier, intermediate repair is not just a layered closure. In the code book, it does tell us you must close a deeper layer and the superficial non-fascia, non-muscle fascia there to be able to call it a layered closure, to be able to call it an intermediate repair. So just because they use two different strands of, maybe they sew one layer up and then they use the dermabond at the top to kind of close it off there, that's not necessarily a layered closure, or it's not necessarily an intermediate repair. So that's something you want to be careful of. Sometimes the doctors will say, I did a layered closure, but it's not, according to the code book, not necessarily intermediate repair. Again, from your references perspective, really good information in the book and also in your CPT assistant articles there. Also remember that single layer but heavily contaminated wounds can also count as intermediate. So if you've got someone who was in a motorcycle accident and they have gravel and dirt and things, and it has to be very much cleaned out before you can repair it, that also can count as an intermediate repair. Just a little bit about adjacent tissue transfers. I just wanted to give you some definitions because sometimes the code book doesn't always do a great job of giving you that. So I just put in some information here when you're going back through your handouts. I hope this will be helpful for you as far as what do they mean by pedicle graft, advancement, Z-plasty, W-plasty, and VY-plasty. So I just wanted you to have that in there as we're going through. In the skin replacement surgeries, basically that is the term for skin graft. When you are using a skin graft, remember a graft or the skin replacement, you can get that either from that patient, that would be autologous. The word A-U-T-O, auto, means self, or that they get it from that particular patient. You can get it from allograft, which means it comes from a deceased patient, or you can get xenograft, and xenograft come from an animal. For example, pig skin works very well for big areas such as burns, where patients need to have a large area of skin grafting done, because that does match very similar to your human skin. So you need to know where the skin comes from. They can also use some culture to grow skin from the patient's own cells, and so you can do those as well. So you're looking for the word autograft as well, which tells me that it comes from that patient. The codes are going to be coded to the recipient area, not to where they get it from. And typically with the skin replacement, if they get it from that person, let's say that I have it on my belly and they're needing to move it to my scalp, then they can cut it off and move it. That is really the definition of skin, grafting when you're using it from that same patient. Remember that if they don't actually cut it, but they actually tunnel it, or they keep it connected to the blood supply longer, that's going to be in the flap area. So that's different from the skin replacement. Now, typically in this area, you will see the measurements. It'll say the same as we saw with our lesions, where it might say like 4 by 6. But remember, now we're talking about the whole entire diameter there, not just like our laceration. So laceration, we're going to go, if it says like 4 by 2, we're going to just code the longest amount there. But in our skin replacement, you want the whole entire circumference. So you're going to multiply that together. So if it is 4 by 6, 4 times 6 to get your total amount there. So make sure you watch those carefully. Again, that's one thing about CPT. The rules are different on every single code, every single page. You got to make sure you really watch those. As I mentioned, those are coded to the size and location of the recipient site. They're coded to the type of graft or skin substitute. It does include simple debridement or cleaning of the area, but you do want to make sure that you're watching to see if there are anything else that may need to be done, such as harvesting, if they get it from that same patient, or other types of procedures that may be done. Some patients need surgical fixation, so you might need to code some more procedures there as well. From those codes, we go into the destruction codes. As I mentioned earlier, those are anything other than excision. And remember, these are also destruction of benign or pre-malignant lesions or malignant lesions, any method. So again, with your destructions, you still need to know, if possible, the type, if it's benign or pre-malignant or malignant. And then the last part of our integumentary section is on the breast procedures. Remember that you've got biopsies, you have simple biopsies, incisional biopsies, excisional biopsies. Basically, when they're removing lesions or doing something with the breast, you've got a couple of different levels there. First off, if they're doing a biopsy, you have to know if it's a needle biopsy, an open biopsy, if they're just taking a piece of that particular lesion, or if they're taking the whole thing. There is no code in this area for excisional biopsy. If the doctor says that, that means they took the whole entire specimen. The whole specimen is the whole lesion, but there's not a code for that. So an excisional biopsy means that they removed the whole entire lesion, and you would code that to excision lesion. Okay, there you've got different methods of image guidance. There are biopsy, needle, open, incisional, or percutaneous. If they used image guidance, that also can make a difference in the code. Sometimes they'll use assisting devices like vacuum assisted or rotating. That'll make a difference. And sometimes they will put in a little clip or a wire. These can be two different things, so you want to watch. Now, I will tell you that in the changes that are coming out on January 1st with 2018, they have made it very clear with any mastectomy codes that if they do put in a clip as part of those procedures to mark where that lesion was, or to save the space for later when they come back and do like radiation therapy, that if they put in a clip, like a magnetic clip or a radioactive clip basically, that can be seen under radiology, that is not coded separately during another procedure for a mastectomy. Please remember that mastectomies can be partial mastectomies, which is going to be like a lumpectomy. And the difference between excision of a cyst or a lesion and then a lumpectomy is where they know it's cancer usually, and they're removing not only that lump, but they're also going to remove some breast tissue from around it. That makes it a partial mastectomy. So whether it's a lumpectomy, tielectomy, quadrantectomy, whatever, if they're removing breast tissue, that's going to be a partial mastectomy, not excision of lesion. So be careful with that as well. Now, the wire is typically used when you're getting a patient ready after they've had a biopsy and they're going to go in for surgery, like for a lumpectomy. That's different from putting in a clip. The wire is where they're going to, under some type of guidance, such as radiological guidance, mammogram, for example, they will go in and they will see in the ultrasound or the radiology, whatever it may be, they'll see exactly where the problem is. And again, that clip that's been placed in already, that's sometimes very helpful. Then they will lead a wire from the outside of the patient's skin into where that clip is. So basically it points the direction. Now that wire is going to be taped to the outside of the patient's body, and then they're sent down to surgery, because that way the surgeon does not have to make such a large incision. It's less disfiguring. They're able to get to that very quickly, especially when we talk about those little bitty lesions like in the ducts, like the intraductal carcinomas. Think about how big a milk duct is. It's tiny. Those are tiny little cancers, and they want to make sure they get right to them. So all of these procedures are very, very important in making sure that the doctor has everything they need to be able to take as good of care as the patient as possible. So watch for all of those codes in the last part of the breast procedures there. As I mentioned here, we talked about that partial lumpectomy, and also if they do a bilateral mastectomy, you would want to use modifier 50. Remember that even though typically we can use left versus right, if there are two different procedures and they do something different on one side, like maybe a biopsy on the left side and actually a lumpectomy on the right side, well then that's going to be separate codes, and you would use left and right modifiers as appropriate. But remember, when you have a paired body part and they do the same exact procedure on both, then that's when you would, instead of using the left and right and coding those separately, separately, you would use modifier 50 instead. And that's not just true here, that's true anywhere in the code book. Modifier 50 takes precedence over left versus right if they do exactly the same procedure on both sides at the same time. From there, let's move over into the musculoskeletal. And again, I'm going to start trying to pick up the pace just a little bit because I've got a lot to give. Remember, you have the handouts for anything I don't get to today. Musculoskeletal, biggest thing is reviewing those rules at the very beginning of the book. What is the difference between an open versus a closed treatment? Please remember you might have an open or closed fracture from a diagnosis perspective, but you're going to need possibly to do an open treatment of a closed fracture if it is necessary. Also, open treatment would include not just surgical openings, but also remote opening of the fracture site to place in the intramedullary implant or nail. Okay, so that's another addition to the open treatment. The other term there that sometimes is confusing is manipulation, and that is the attempted reduction or restoration of a bone to its normal location when you're talking about a fracture. They tried to put the bone back where it needs to be. Whether they were successful or not, they still tried. That's manipulation. So you'll see codes that'll say either with or without manipulation. Like our biopsies in the integumentary system, typically the biopsies, if they're, they can be coded separately unless the code book tells you not to. You do need to know the type of instrumentation used, if it's a needle biopsy, trocars, if it's an open biopsy. A lot of these will use terms like superficial versus deep, but the code book does not always define what they mean by superficial or deep. So you might want to take a look at those areas, and typically if that structure is very close to the outside and we're just getting something off the very edge or in the outside part of it, that's going to be a superficial. If they go to the inner side of that bone, right around the bone marrow in that area, or deep into the muscle, then that would be a deep one. So sometimes it's not always real clear in the code book, and you just want to look for documentation and see if you can code it as best as possible. You want to watch out for your S's. Whenever you see anything in CPT anywhere in the book, when it is in parentheses, then that means it is a rule, it's an instruction. And that's true anytime unless it has an EG or IE. EG or IE basically mean for example. So if you see something in parentheses and it says EG, biopsy, that means that's just one example and that's not absolute. But when you see anything else, then that is absolute there. The one that's most common that is problematic is the one where you have an S with the parentheses around it. That means it's once per session. So if you see code for an injection procedure and it says injection with an S, that means that whether they do one injection or 5, you only can code that one time. And I gave you the example there, and these are actually in the musculoskeletal. The codes are 20550 and 20553, that area. For it's like the trigger point injections, they'll say injection or injections. They may even say muscles, but then it says 1 to 2 muscles or 3 or more muscle groups. So that's the dividing factor. So you really want to be careful to make sure you're coding those appropriately. It uses a word like single, or it'll use each or up to, every. You just really have to be careful in CPT. But the S in parentheses means that whether you do this once or multiple times, you can still only code it one time. In the treatment of fractures, remember those are coded to the type of fracture, if it's open or closed, the type of procedure, open, closed, or skeletal fixation, and then by site, femur, femoral shaft, for example, and then either with or without manipulation. Remember the term manipulation means attempted reduction, and also it may change the code assignment if the traction is required. As I mentioned earlier, the type of fracture is not included in the repair of the fracture, so you might need to do an open reduction or treatment of a closed fracture. So don't let your diagnosis confuse you when you're looking at the fracture procedure type. If you do any kind of procedures with the spine, the vertebroplasty is where they are injecting cement type material into the fracture itself. Vertebroplasty is simply just doing that, putting the cement material into the fracture. However, if they augment it, not only do these are used if you have a bone that is collapsing on itself. We're trying to make it stronger, but sometimes they will do augmentation. They will use a bone or a, basically using maybe they've used a grafting, and they'll put it in there as well, and then it pushes it up, so now your bone is the right height again, like in the vertebral bones. If there's a crushing or a compression, they will put that bone in there or some type of a graft to hold it up. They sometimes use a balloon catheter to create an opening, and then they put the cement in there, and even without having to put in any other type of device like a bone grafting, that's still going to make it back to its normal location or not. So a lot of good information there as well. So the augmentation means you're not just putting in the cement, you're also making it at a different level. You're augmenting the size or the structure of that body part and then doing the cement. So those are there in the musculoskeletal chapter. Be careful with excision of tumors in the soft tissue, because if they are actually come from or originate in the skin, even when they go deep, they are coded in the skin chapter, like a malignant melanoma. Sometimes those malignant melanomas go really deep and they are very, deadly. So basically, though, they're going to be in the fascia. They're going to be down toward the bones and stuff. But where do they originate? If they're a cutaneous origin, then those have to be coded in the skin chapter. Even though they may be in the soft tissue, that's not how you code them. And you can get an example of that if you want to look at code 23070. Now I try not to put real full codes in here because the CPT codes are copyright protected, and we're just trying to be careful that we do not violate their copyright protection. That's why you typically do not see, and I'm not showing you pages out of the code book, just because again we want to make sure that we are very respectful of CPT's information there. You also want to look out for that each. I've talked about that earlier, how they say each. Each what? I've given you some examples here of different codes, and these are in treating finger problems like fractures and other things. They may put a rod in, they may do something with the tendons, so it could be each rod, each tendon, each finger, each joint, or each bone. And remember, there are multiple bones in your finger, and so again, you have to know exactly when you're coding those. If it says each rod and you use 2 rods, that's 2 codes. If it says each joint and when you did something on 3 joints, then that's going to be 3 codes there. So just really watch out for that term each. I see a lot of problems with those because people code it, but then they don't go back and say that they may be able to code it multiple times. When you're doing knee procedures like arthroscopic procedures, typically you've got components of the knee, like you have a medial component in the middle and a lateral component to the side. When multiple procedures are done in the same knee compartment, typically the secondary procedures are considered to be incidental and they would not be paid separately. But if you do like something in the medial compartment and then something different on the lateral compartment, then that will be separate. And again, to show that, you may have to use a modifier like the modifier 59. If you do procedures on 2 different knees, 2 different procedures, the left versus the right modifiers will help you with those as well. You want to be careful because there are sometimes in this area talking about the knee compartments. It'll say things like anterior and posterior in some codes, anterior or posterior. Is it one or the other or both? If it says and, that means and. Both have to be documented. Same thing in the next line, medial compartment, lateral compartment. Is it and or is it or? Or means one or the other, you're good. And means to use that code appropriately, both have to be documented there. So watch your coders, your operative report carefully. Another really good reference material is the Coder's Desk reference, and that actually is put out by Optum now, and Genix sold that out to them. I'm sorry for that. But basically, as you're looking through a product like TruCode that has all the different references built in, they're all there for you. They're right there while you're actually coding, and so they're all going to pull up to the right side of your screen. So I use references all the time when I'm coding with CPT because it's not always real user-friendly all by itself. So when I talk about using the CPT assistants and using my Coder's Desk reference, I really do, as a coding professional, use those all the time there. Now, one of the probably most difficult areas in the musculoskeletal is going to be the bunion area. Lots of really great pictures. If you've looked at the 2018 book for this year, they actually made all the pictures in color instead of just black and white. So that made me happy, because if I got to look at that, you know, I want to see that. So basically, it's just a little easier to see that in the book itself that you can use for references. Also remember to review your op report, because they changed last year the terminology for bunions. Instead of saying like a MacGyver procedure, that's not a real procedure, by the way, I'm just making that up, but anyway, if you have a procedure that's named after someone, instead of using that, they've said more descriptively, what are we doing? You know, we're going to take out a piece of the bone in the proximal side of the phalanx, for example. So they changed these a lot last year. So make sure you're reading your op report very carefully. Use your references. Use those resources to help you. And again, the pictures, they're there in TruCode, but also in the code book itself. Also remember, with casting and strapping, you got to be careful when coding these. Typically, out-of-the-box procedures don't count. Those are just really part of your E&M code. You can code the casting or strapping separately if it's a replacement during or after the follow-up, or if it's an initial service performed without actual treatment. Like if they show up at the ER, they may do a casting and then send them to the orthopedic, or do strapping as well. So you got those codes, and you just need to know when you can use them and when you can't. Remember that the scopes, always a diagnostic scope is included within a surgical scope, and so that is considered to be part of the surgical procedure. From there, we're moving on over. Again, I'm just trying to find a little bit in every section to talk to you about. I've kind of skipped past starting with the cardiology. With your pacemakers or the cardioverter defibrillators, remember there's two different pieces of those. You have the battery pack or the pulse generator, and then you have the wire or the leads that go from the battery pack down into the heart itself. And then there's a little electrode at the end of that lead that is going to give you the electrical stimulation needed to make sure the heart's doing what it's supposed to do. So basically, you need to know, what are they doing today? If they're just replacing the battery pack, they're taking the one that's existing out of its little subcutaneous pocket and putting a new one in, well, then you're only going to have a code for replacement of the pulse generator. If they're putting in a whole new system, then you may have two codes, one for the subcutaneous pocket, putting the battery pack underneath the skin, and then one for the percutaneous, putting the wires down in the heart, because you need to know, are they putting it in the right side or the left side, in the atrium or the ventricles. So we need to know those to be able to code those appropriately. There are some pretty good tables in CPT in this area to assist you in being able to code those appropriately. The cardioverter defibrillators are just like the pacemakers, except they have an additional lead on them that is an actual, like a shocking mechanism. But as far as the way that they're put in, they work pretty much the same there. Probably one of the hardest areas in cardiovascular is the selective catheter placement. Remember that you do have the first, second, and third the order of those different vessels, and there's a really good appendix in the back of the CPT book, Appendix L for vascular families. I use that a lot. Again, good reference tools if you're using, like within TruCode, we have an interventional cardiology reference that is excellent, and you may have some of those as well, but basically those I find to be very, very helpful, because I think that selective catheters are pretty hard. And again, CPT Assistant has some excellent articles in those references as well. Your venous access devices, those basically are going to be like your PICC lines and your other, basically they're put under the skin, and they allow your medications to be delivered to your larger veins, and they can be left in for long periods of time. Those are your venous access devices. These are also terms used in the same area, are going to be venous access ports, portacats, access catheters, CVAD, central venous access device, or PICC lines. PICC is that peripheral, that's a line that's put into your arm, as opposed to a central line is put into the neck or chest region in the central part of the body. So you've got catheters that are inserted if you've got a central line or a central port, where they take a catheter, they insert it, they tunnel under the skin into the subclavian vein beneath the collarbone, and that's why they're called tunneled catheters. And that's an important description in the coding book that is going to help you within the codes themselves to code those appropriately. Part of the catheter where the medication is given may be left externally, or it may be closed over with a piece of skin, especially like with kids, so that they can't pull those out. And that's going to be really great for patients who do have long-term needs, such as chemotherapy for cancers. As I mentioned, the PICC lines, peripherally inserted central catheter or peripherally inserted catheter lines there, and those are inserted into a large vein in the arm, and then they're advanced forward into the subclavian vein as well. The procedures, you need to know where the tip is ending up. Is it in the subclavian, brachiocephalic, iliac vein, the vena cava, or the right atrium? Or maybe it's inserted peripherally through the basilic or the cephalic vein. And again, is it exposed through an exposed catheter, a subcutaneous port, or an actual subcutaneous pump? Those all make a difference in your code assignment. There are different codes for insertion, repair, partial replacement, complete replacement, or removal of those devices. So you got codes for insertion, you got codes for repair, you got codes for removal. Okay. As I mentioned, tunneled versus non-tunneled. Tunneled means they place, non-tunneled means they're placing the catheter directly into the venous system, where tunneled is where the catheter is tunneled under the skin and they want that catheter embedded for the long-term chemo or other long-term usage. They can put a port or a pump installed at the end of that that may hold medications, and instead of just hooking up the IV that day, it actually is going to give out medications even after the patient goes home. So that may be different from just a regular portacath, for example. Many times the codes are going to be like they'll talk about dual or single, and I always like to have brand names of catheters that we use in our facility, so that's going to help me to be able to translate what the doctor says we put in a Broviac catheter today versus what I need to know to be able to code those correctly in using CPT. The next area is going to be our digestive system. The first ones are going to be our scopes. Esophagoscopy, if they're going in through the scope, these can be either flexible or rigid scopes, so you need to know the type of the scope. Again, this is where I think it's very important to have a cheat sheet or help sheet. We're calling it a help sheet because cheat sheets get a bad name. But basically, what scopes do you use in your hospital or surgery center? Because that's, again, the way the doctors dictate, the way they write down their information. In their op reports, they say, I used an Olympus 485 scope was used today. Well, I don't know if that's a flexible or rigid. I don't know if that's an operating microscope or if it's the actual, just the scope that we use on the EGDs. And so that is going to be real helpful for me to have that, to be able to make sure that I know without having to ask a lot more questions or query the doctor about what they actually did today. And also remember to watch for any secondary codable procedures. If during scopes, and this is true with the esophagoscopies, EGDs, or even colonoscopies, they can also do other procedures, removal of polyps. They can use India ink or some other type of marking. That is an additional add-on code that I can use to be able to code appropriately. If they biopsy one lesion and remove another, two separate codes. Might I need a modifier? Maybe so, but I definitely want to make sure I'm coding those. The EGD is going to be an endoscopic procedure, upper GI, coded according to the type of procedure done. Again, they can do a biopsy. They can do an excision of the lesion. If the biopsy says single or multiple, you only use one code per session for any number. Whether they've done 5 biopsies or 1, it's still only one code. Sometimes it'll say biopsy single or multiple. Sometimes it'll say biopsy and then in parentheses IES. Either way means you can only code them once. Now, when your doctor is doing multiple procedures within the same family, where, like I said before, maybe they biopsy one, they excise a lesion, they may also destroy a lesion, that can actually be 2 or 3 different codes, and you should not need a modifier with that, but sometimes I found that that may be helpful. Check your edits list to see if there is anything else that may need to be done to make sure you're getting paid for those appropriately. Remember when I talked about add-on codes, things like submucosal injections, that's an add-on code. We want to make sure we're coding that. Sometimes the doctors don't document that very well, but that's additional work value for them, and we want to make sure that we're coding that as appropriate. Removal of polyps, again, whether it's through an EGD or a sigmoidoscopy or colonoscopy, you need to know how many are removed and also the method. Many of those codes have the S in parentheses, so it may not be the number of things removed. It is the removal, the method of removal. They can do a snare technique, they can do hot biopsy forceps, they can do ablation. You want to be very careful because I was just talking to a coder yesterday about this. When they do a cold biopsy, that is different from a snare. There's really not a code for a cold biopsy by itself. If they talk about a cold snare, well then that's a snare code. If it's a hot snare, that's a cold. But if they say cold biopsy forceps, that's a biopsy. So those terms, you want to be really careful there. They're not always the same thing, and sometimes they do get to be confusing. The ERCPs, endoscopic retrograde cholangiopancreatography, basically means that when they're looking at the liver and the biliary systems, they may also look in the tubes, the vessels, and so you want to make sure you're coding those as appropriate where they're actually putting in or they're canalizing any ductal system. Like if a patient has a stone in one of those ducts, they may put in they may open that up to look in it as well. The gastric bypass codes in the middle of the digestive system, be careful with those. Those procedures can be done either open or endoscopically, and there's also codes for like bands or restrictive devices being put on the outside of the patient's stomach or intestines there to work with the bypass. So you need to know exactly what it is that the doctor's doing. With your colonoscopies, there is a really nice decision tree. You'll find that in the code book, or if you're looking at it in TruCode, you'll see it there as well. And there are very specific notes that tell us exactly what to do if the patient does not, or the scope does not go past the splenic flexure. Then that is going to be a sigmoidoscopy, even though they meant to do a colonoscopy. If it gets past the splenic flexure, that bend, but they don't get all the way around, then that's where you're going to use a modifier. In the code book, it does tell you to use modifier 52 or 53. Remember, those notes are for physicians, and so you want to make sure that you are not using those. If you're coding for the hospital, you're probably going to use modifier 73 or 74 there. Okay, same thing with the scopes. Again, I'm going to move on from there. And we've already talked about the removal of the polyps, same thing we talked about with the EGDs a while ago. With hernia repairs, the location and the type of hernia is very important. Also, sometimes with this mesh, there are certain types of procedures that if they use the mesh, you can code that separately. So you need to know that also. And sometimes even the age of the patient is included in the appropriate code as well. Now we're going over to the female reproductive. I know that hysterectomies, there's lots of different types of hysterectomies. I just wanted to give you this information here about what they mean, like when they say, you know, laparoscopic versus vaginal versus open procedure. If they do have to remove, if it's a very large uterus that they're getting out through the vaginal tract, there may be something else they may need to do there. So that may be, the sizing might be an important part of choosing your code correctly. Again, just trying to give you information. These slides I'm going through very quickly because I'm just giving you definitions because I get questions on those all the time. Okay, so that took us through. We spent a lot of time today. I know it seems like, gosh, we just got started, but we were already 45 minutes into this presentation. Just wanted to quickly go through some areas for you. And everything that I've talked about today, your slides look just like mine. So if I went through some of those really fast, or there's areas that you need more help with, you've got the handouts. You can go back through that and read through those definitions, trying to give you things that I find are problematic when I'm doing audits or that people have questions on in my classes when I do seminars. So I just wanted to give you that information. Our last topic really today is the use of modifiers. However, I have been talking about modifier usage as we've gone through today. So whenever you have a code where the code description does not exactly match what the doctor had to do, that may be that you need a modifier. These are reasons why you might need those. And remember, when they set up the system, they realized that there was not going to be a perfect way. You weren't going to be able to code everything, but modifiers can be used to change the description in a predictable manner. So if we didn't finish it, only one part was completed. Bilateral, we talked about that earlier. If a procedure has been increased or reduced, if it was unusual, or if it has both a professional and technical component. Those can be reasons why you might want to use a modifier. Now, I've tried to put a lot of modifiers in here today. Again, I'm going to highlight the ones that I think are the most important. Please remember that anatomic modifiers should be used anytime, not just on Medicare charts, but anytime they best describe, give you more information about the patient's condition. In particular, left versus right, you should always use those. And typically, remember, you can use multiple modifiers together. So if you need to use left on one of them and right and modifier 50 or modifier, or excuse me, not 50, but 59, you can use those as well if you're trying to tell the story. So use those to show exactly what's going on. If you are coding any E&M, so there's a medical visit and there's also a procedure, then you can use modifier 25. This is probably one of the most controversial modifiers, because basically what you're doing when you add a modifier 25 to a medical visit, and that means that there's a procedure done at the same time, modifier 25 says you've done above and beyond what it took to do that surgical procedure, because there's always a medical component of every surgical procedure that is not separately codable unless the documentation shows that you went above and beyond what it takes to do that procedure itself. Medicare, asking them some questions, they said that basically with Medicare you should append to an E&M code when reported with another procedure on the same day of service. Appending this indicates that as a result of the patient's condition, the physician performed a significant, separately identifiable E&M service above and beyond the other service provided. And that's what I said a minute ago, above and beyond. So there's documentations to support that these are separate. It does not necessarily mean you have two different diagnoses, because CPT says that that's okay, but we've just got more, we did more than just the procedure itself. Okay. We talked about modifier 50, and I told you that for bilateral, if you're trying to decide whether you should code out when a procedure is done on both sides at the same time, if you're trying to decide if you need to use a left versus right or modifier 50, Medicare says modifier 50 takes precedence, and it should take precedence because it's more specific there. Again, here's Medicare billing rules. They tell us that they will use modifier 50. If you try to use it twice, and it could be done bilaterally, their system is set up to delete or not pay or reject the second one. Typically, they pay about 150% of the value, because there is a cost savings to doing two sides at the same time. Modifier 52 is used for reduced services where the doctor has decided at their discretion to not complete a procedure. Again, we don't use that very often. If you are coding for the hospital, you're going to use probably the 73 or 74 is most common there. Medicare question and answer, should modifier 52 be used for a procedure that is defined as bilateral by the codes when the doctor was able to perform only one side? So the actual procedure itself has the term bilateral used. So should I use modifier 52? And Medicare says absolutely. That actually is a really good reason why. It says because unless the specific CPT description contains language indicating that the test, procedure, or service is unilateral or bilateral. Okay, so again, basically you want to look out for that as well. Modifier 59 is another one of the most controversial of all of the modifiers. Basically, that is used only if no other modifiers tells the story, and it means that you have two services that are not normally billed together, but because of the circumstances, you have to do that, or basically you should be able to get paid separately because there are two different problems that day, two different body parts, whatever the reason might be. When you see your edits for bundling edits and you get a note that says you need to use a modifier to get past that, 59 many times will help you get past that modifier. However, I see this being used incorrectly. People are putting modifier 59 on when they're not checking to see if the documentation supports it. Yes, you could get paid for it separately, but is there documentation to support getting paid for it separately? So be very, very careful. Infusions and injections, that's a big area with modifier 59. This is a Medicare Q&A. In what instances can I use this modifier to designate a separate, different site? It says if none of the anatomic modifiers are used appropriately, can be used, then you can use modifier 59. Now remember that a couple years ago Medicare put in the X modifiers and have requested that we not use modifier 59 for Medicare purposes. However, some insurance companies do still accept, actually most do still accept modifier 59. I've given you the link to go out and read about the X modifiers if you're not as comfortable with those. And here they are. These should be used for Medicare, and I am starting to see more other insurance companies, such as some of the Medicaids, that they are starting to accept these as well. And what I have also noticed is that sometimes people will use a modifier 59, but if that insurance company does not accept them, it won't give you a denial. It just won't use it. It won't give you credit for the second procedure. So you really want to pay attention to these X modifiers and see if you need to be using them. These are really like divisions of modifier 59 instead of using 59. XE is a separate encounter, XS is a separate structure, XP is a separate practitioner, and XU is an unusual non-overlapping service. So that's kind of the most 59 of all of these. It's kind of like nothing else explains it better than that. So again, just wanted to put these out here, reminding you that these are very important, that you are using them as appropriate for Medicare and others. If you do the exact same procedure more than once during that episode of care or that date of service, if you do that procedure multiple times and it's exactly the same procedure, use modifier 76 or 77 on the second procedures to show that they are repeat. So otherwise it will look like those are duplicate bills, and so you may get a denial of those. So don't put it on the first one, put it on the second one. So let's say the patient needed thoracentesis that morning, the doctor did that, they had a buildup of fluid, they had to come back in later that day and do another thoracentesis. That is exactly the same code. I would use a 76 if it's the same physician or surgeon doing that procedure the second time. If it's a different doctor, then I would use a 77. And then we have the second procedure done either that date of service or for our physicians done during the global period. These can be used to show that the patient had a separate surgical procedure performed. 58 is a staged or related procedure. 78 is a related return to the operating room, and 79 is an unrelated procedure. For the one for staged, the 58, an example of that where they did a needle biopsy that morning, they did pathology and found out that that was actually cancer. So they did an excisional biopsy later that day. So that would be an example of these are staged or related procedures. Return to the OR. That's where the patient is finished with their surgery. They're in recovery, for example. They start bleeding and they have to take them back to the OR. Why is that important? Because basically that return to the OR is going to show that it's a separate encounter. Otherwise, it's going to look like these are done during the same operative episode, and you'll get a discounting. You won't get paid for two separate operating rooms. So very important there. The last of the modifiers is modifier 91. This is a repeat, kind of like the 76 and 77, but this is for repeat lab procedures. So this is where they have the same lab procedure done multiple times during the same day, for example. So let's say that the patient had a low potassium, we gave them some medication, and then wanted the lab test run again later that day to see if the medication worked. That would be an example of where modifier 91 would be used on the second procedure to make sure to show that it's not a duplicate bill. It actually was a separate procedure done later that day. It does remind us in the CPT book that you would not use this if the test is rerun to confirm results, equipment problems, or if there's already a code for a series of tests like a panel test like that. An example of this would be, let's say a patient comes in and they do a pregnancy test and it comes out positive, and she says there is no way, run it again. Well, that's just to confirm the results. That's not the same as needing to code it multiple times. So that is where you would not be able to actually code that separately using this modifier. As I mentioned, modifiers and atomic modifiers left and right, you should use those anytime it is appropriate. You will get an edit. For example, if you're a TruCode user, we have edits built in the system that will remind you that if it should be used, it'll just to give you a little reminder, and we love those reminders to help make sure that we're not missing anything. So TruCode really helps me with that as well. I told you a lot of stuff today in a very little amount of time, but again, you have the references, you have the handouts, and again, I tried to give you more information than we could possibly get through today, just so you would be able to go back and review those definitions and have a little bit more take home. When I do these classes, I do these with using information from my references, my CPT Assistant, Coder's Desk Reference, my Coding Clinic for HCPCS. That's where I got all the questions and answers. So those are some excellent references and resources that will help make your job a little easier when you're trying to code procedures. So I am going to turn it over to Sharon, and she is going to talk to you about getting your CE and anything else you might need to know. Sharon?
Karen. Everybody, I just wanted to give you the instructions for accessing your CEU certificate, which you'll also see on this on the screen that Karen has up. This is the link to access the evaluation, so you can enter this into your computer to the address bar, and you can enter complete a brief evaluation, and then you'll be brought to a link to download your CEU certificate. But we will also be sending out an email tomorrow, and that will contain a link to the recording. It will also contain handouts. And if you have any questions or don't receive that, please send me an email, but just know that that will be coming out tomorrow, probably by noon. Thanks everybody for attending. Karen, I don't know if there's anything else or if we can sign off.
I think we're good to go. Thank you so much for attending today, and we appreciate y'all, and let us know if we can help you in any way at TruCode. Have a great rest of your day and a happy holiday season. Bye everyone.